نداشته باشه. Hello everyone, it's 6:30 p.m. now in Iran and it's time to start the program. First, I will briefly introduce myself. I am Dr. Marjan Yaghmai, Associate Professor of Medical Genetics at Oncology, Hematology and Cell Therapy Research Institute and head of the leading house for Iran and North America Academic Partnership. We are pleased to present the 11th part of Tehran University of Medical Sciences How I Treat Hematologic Malignancies series entitled How I Treat Hodgkin Lymphoma. This educational series was realized with help from the Oncology, Hematology and Cell Therapy Research Institute, the Appraise to Raise team and support of the Vice Dean for Educational Affairs of the International Campus. I would like to express my most sincere gratitude for the support and welcome to this educational program. It's a great honor for us to have you all here, at least virtually. Before we start, I would like to thank our invited speaker, Dr. Eradat and Dr. Maziar Shadman, Associate Professor of Medical Oncology at the University of Washington, who kindly facilitated these connections. I'm now asking Dr. Shadman to introduce our valued guest speaker, Dr. Eradat, and following that introduction, we will start the program, and Dr. Waizi will moderate this program. I hope you will find this webinar informative and helpful. Dr. Shadman, please.
Thank you, Dr. Yaghmai. It's my pleasure to introduce my colleague and friend, Dr. Herbert Eradat. Dr. Eradat is an associate clinical professor at the UCLA and a specialist in lymphoid malignancies. He's the director for
Dr. Shadman, can you hear me?
Yes. You can't hear me?
We can hear you.
We can hear you. Yep. Mute. Okay.
No, I think everybody can hear me, Dr. Yaghmai.
Yeah,
you can hear me now, right?
Yes, yes.
Okay. You know, I'll start again, so to make sure. Yeah, so it's my pleasure to introduce my friend and colleague, Dr. Herbert Eradat, who is an associate clinical professor.
I cannot hear you, Dr. Shadman.
Sorry, Dr. Shadman, could you not close your video? Whenever you close your video, Dr. Yaghmai couldn't hear you. I don't know why.
Okay. Can anybody else hear me when I'm speaking, or is it just Dr. Yaghmai?
No, I can hear you when you're speaking.
Yes, we can hear you.
Okay, well, I'll try again, but if not, we'll figure it out. So it's my pleasure to introduce Dr. Herbert Eradat, who is an associate clinical professor at the University of California, Los Angeles, UCLA. He is the director for a clinical research program for chronic lymphocytic leukemia and Waldenström macroglobulinemia. Also has a new role in directing and expanding the T-cell lymphoma and cutaneous T-cell lymphoma programs at the UCLA program. He's focused on lymphoid malignancies, and his research focuses on a range of immunotherapy, cellular signaling, and apoptosis in patients with lymphoid malignancies. Dr. Eradat was born in Tehran, completed primary and secondary education in Iran, then moved to the United States and finished his undergrad training at the UCLA Medical School, at the Chicago Medical School, and then internal medicine and fellowship training at UCLA. It's a pleasure to have him as a speaker today, and I will let him continue here. I hope you heard me, but if not, we can.
Yes, we did, sure.
Okay.
Loud and clear. Thank you so much. Thank you so much, Maziar and Dr. Yaghmai and everyone really for the kind invitation. Let me see if I can share my screen here. Can you see my shared screen?
Yes.
Okay, perfect. So again, as I said, it's a pleasure. And again, thank you so much for this collaboration and for inviting me. I'll talk about Hodgkin's lymphoma really as most of my talk is sort of tailored exactly as the title of the discussion was mentioned, in terms of really how I manage Hodgkin's, but I'll certainly heavily present the data that has led to kind of our management strategy. In the beginning, I'll talk about diagnostic approaches and risk stratification in management of patients with Hodgkin's lymphoma. Let me just adjust my window since this, okay. This is a relatively uncommon, Hodgkin's is a relatively uncommon B-cell malignancy, at least if you look at various prevalence cohorts in the United States or Western Europe. Really, it tends to be about 10% of B-cell lymphomas. In terms of its incidence, I think as the audience may be aware, there is really what we refer to as a bimodal distribution. In other words, there's a group of patients that are diagnosed in in adolescence and early adulthood. And then there's a second wave of patients that are diagnosed later in life, around the age of 55. We don't really know what the cause of the disease is, and there are no clearly defined risk factors for the development of disease. There are some suggestions based on epidemiologic studies, mainly familial factors, viral exposures, and immune suppression. I'll delve into this just very briefly because it factors into subsequent therapy, or the modern era of therapy now. Overall, this is really there's a fair amount of data and advances in both radiation therapy and chemotherapy and novel agents that have led to increased cures for patients. So globally, if you take everybody with the diagnosis of Hodgkin's lymphoma younger than the age of 60, probably around 80% of patients are cured of the disease. I alluded to some of the factors associated with Hodgkin's lymphoma. There's certainly genetic causes. This is a suggestion that is made based on population studies and family cohorts. So if you look at patients that are diagnosed with Hodgkin's, their same-sex siblings are at a 10-fold higher risk. So again, suggests either an underlying genetic predisposition to the disease, or some sort of an abnormal immune response, because there is a clear association in some patients with an association with infection. What I mean by the association with infection is, again, some of it comes from epidemiologic studies. So we do see evidence of Epstein-Barr virus, both in serologic studies and epidemiologic studies associated with Hodgkin's lymphoma. In patients with Hodgkin's lymphoma, about 30% of the time, you can actually detect EBV genome. So there is a suggestion that there may be an association, at least in some patients, with Epstein-Barr virus. Interestingly, when you take a history, this comes up all the time, that there is a negative association with infections. So typically, the typical patient that I actually see, young patient that comes in with the diagnosis of Hodgkin's, actually says that they've been healthy all of their lives. They never had any problem. They never missed school. They never had colds or flus or anything. And here they are diagnosed with Hodgkin's. And again, by the same token, if you look at epidemiologic studies, those patients that have had prior chickenpox, measles, mumps, rubella, they are less likely to be in the group of patients that are diagnosed with Hodgkin's lymphoma, suggesting that perhaps some of the prior infectious and challenge to the immune system, so to say, is perhaps protected. The other way around also, if you look at things that really clearly suppress the immune system, so patients that have HIV, or patients that, for example, are on chronic immunosuppression after organ transplants, are at an increased risk of developing Hodgkin's lymphoma. So clearly there's an association from the immune system. Some of the basics here, I think, just so that you're aware, according to the most of when we are referring to Hodgkin's lymphoma, we're actually referring specifically to classical Hodgkin's lymphoma. But the WHO actually defines Hodgkin's lymphoma as two distinct entities. One is the classical Hodgkin's, but there is also a separate entity of nodular lymphocyte predominant Hodgkin's lymphoma. And I'll talk about this just briefly, just to put it in perspective. There are 4 pathologic subtypes of classical Hodgkin's, the nodular sclerosing, the mixed cellularity, lymphocyte depletion, and lymphocyte rich. This can become quickly very, very confusing because of this very overlapping terminology between lymphocyte depletion, lymphocyte rich, nodular lymphocyte predominant. So you have to just be very, very careful in terms of being meticulous in terms of what state we're talking about. Now, specifically regarding classical Hodgkin's lymphoma, this is a lymphoma that is characterized by the presence of these multinucleated Reed-Sternberg cells in a very characteristic reactive cellular background. The reactive cellular background is typically a mix of T cells, eosinophils, and the typical presentation for most patients is a painless adenopathy, typically in the cervical regions. For the nodular sclerosing subtype, this is the most common subtype. Usually this is what we see in patients that are younger, so adolescents and young adults. And they usually have localized disease with cervical, subarachnoid, and mediastinal region. That's the majority of the patients. There is a mixed cellularity subtype. This is really seen in pediatric groups, so even earlier than the adolescent age group, and certainly in the older adults in the second wave, we would see more mixed cellularity. The lymphocyte depletion Hodgkin's lymphoma has a lower incidence, and in fact, I think there's a suggestion that perhaps a lot of the previous cases that have been described are actually fitting in other categories, even including sometimes fitting in a diffuse large B-cell lymphoma. The ones that are really truly have lymphocyte depleted classical Hodgkin's really tend to be older patients or those that have some sort of an acquired immunodeficiency syndrome. They usually have much more extensive disease at presentation and much more symptomatic. And then the lymphocyte-rich variant are similar to the nodular lymphocyte predominant Hodgkin's on morphologic grounds. Now, one thing I wanted to highlight is generally it's thought that the nodular sclerosing subtype does better with therapy, and the other subtypes have a poorer response. That's certainly a possibility because we're talking about a different disease biology in each of these subcategories. But I must say that, and we'll talk about risk stratification and selection of therapy, we do not alter the selection of therapy or the course of therapy typically based on this subgroup classification, even though some, based on some available text, some of the subgroups do worse than others. The current risk stratification does not include this particular subgroup assessment for classical Hodgkin's. Just to put it in perspective, the alternative or the other category of Hodgkin's, the nodular lymphocyte predominant Hodgkin's, this is a unique pathologic entity. Why is it referred to as Hodgkin? Is because it shares the same clinical phenotype, which is that Hodgkin's usually is thought to spread from one lymph node group to adjacent lymph node groups. That's the pattern of progression. And that's what you actually see also in nodular lymphocyte predominant Hodgkin's lymphoma. In terms of the pathology, there are no Reed-Sternberg cells. Typically, what we see are really folded these LNH cells that are lymphocytic and histiocytic cells that are larger and folded lobulated nuclei. So that morphologically they're different than, certainly far different than the classical Reed-Sternberg cells. Classical Hodgkin's lymphoma typically is CD30 positive. Nodular lymphocyte predominant is usually CD30 negative, and this disease is typically CD20 positive in contrast to, again, classical Hodgkin's lymphoma that is typically really, it's rare to have a CD20 positive classical Hodgkin's lymphoma. This is typically seen more in men. Usually patients have symptoms at presentation, and it's very rare for them to have extranodal involvement. And one thing I would just say, aside from the clinical presentation that is really very much similar to, or the pattern of spread, I should say, is similar to classical Hodgkin's lymphoma, this disease, the natural history is somewhat different in the sense that for most patients with classical Hodgkin's, if they're, as I said, 80% of patients with classical Hodgkin's are treated and are cured, versus this particular entity behaves more like an indolent non-Hodgkin's lymphoma with a tendency for repeated recurrences and even late recurrences. And then finally, this is the last slide regarding the biology, and this, because it factors into newer therapies, I just will highlight it here, that there is indeed over the past decade now, a plethora of data suggesting that PD-1 ligand is highly expressed on Reed-Sternberg cells. This is really primarily because there is amplification at the 9th chromosome and in the 9p24 region, and this leads to increased expression of PDL1 and PDL2. And what this means biologically is that the Reed-Sternberg cell is now protected from the immune response, the T cell mediated killing. And in that context is where we are really seeing highly efficacious therapeutic modalities with modern PD-1, PDL1 blockade. And I'll come back to that when I'm talking about the treatment strategies here. Now, moving a little bit more rapidly in terms of clinical presentation, as I said, really most of the patients with classical Hodgkin's have adenopathy in the above the diaphragm. Involved in the abdomen is less common, and it's, again, as I said, the classical pattern is contiguous lymph node spread. There certainly can be direct invasion into surrounding structures, and also there can also be hematogenous spread. There certainly can be extranodal involvement, either by direct invasion, certainly by hematologic spread. It can spread to other organs. Typically, I have to tell you that in a patient that is immunocompetent, usually the disease follows that pattern that I already mentioned, which is it's a spread through contiguous sequential lymph node groups. What you see in patients that are immunocompromised, the HIV patients or patients that are on immunosuppression, is really that pattern of spread is disrupted, and so patients can have hematogenous spread that is not necessarily fitting the typical sequential pattern of lymph node spread. And then a third of the patients actually present with what we refer to as B-type symptoms, which are fevers, night sweats, and weight loss. And these are specific characteristic fevers. So the fevers are referred to as Pell-Epstein fevers. They usually have a repetitive characteristic. Night sweats are usually drenching. This is not just simply damping. And weight loss is considered more than 10% of the baseline. And also specific to this disease or unique to this disease is chronic pruritus. I think I need to emphasize really in terms of diagnostic considerations, you need to make obviously you have to make a diagnosis with a biopsy. This is not something that you can diagnose based on blood work or flow cytometry of the peripheral blood. And really for the first diagnosis, it really needs to be a good tissue sample. So an excisional lymph node biopsy or a large portion of the mass should be excised by a surgeon. Typically we do not, certainly we would say fine needle aspiration is completely inadequate. Core needle biopsies are becoming more and more acceptable, but really we make every effort in the first diagnosis to make sure that we have adequate tissue to be able to evaluate the nodal architecture, the surrounding inflammatory components, and also certainly in the modern era, there's a fair amount of testing that can be done in terms of various Epstein-Barr virus expression and checkpoint inhibitor, checkpoints like PD-1, PDL1 expression, which again factor into potential therapeutic options down the road. So I can't overemphasize that really for most of the diagnostic workup, you need to at least initially excise the lymph node. In terms of additional workup that we do, this is recommendations from the European Society of Medical Oncology. So in terms of beyond the diagnosis, you need to do staging and risk stratification. The staging obviously requires an evaluation by physical examination, assessment of lymph node compartments, and X-ray is part of something that is useful in assessment of mediastinal masses, because the definition of bulky disease is based on the size of the mass on a X-ray. In the modern era, most of us do a CT scan or a PET CT in assessment of the extent of involvement. For patients that are getting, that do not have any abdominal disease, there is no necessity to do a bone marrow biopsy. There was a very large study from the Vancouver group suggesting that really typically you don't, in an immunocompetent patient, again, not in someone that is immunocompromised, but in an immunocompetent patient, there is very, very little utility to doing a bone marrow biopsy if the patient doesn't have abdominal or pelvic disease. So because it spreads in that, first to that compartment prior to spread to the bone marrow. In the modern era of PET, you may not even have to do a bone marrow biopsy, especially if the PET scan will pick up the bone compartment, but also certainly is very, very sensitive in terms of abdominal disease as well. In terms of risk stratification, assessment of anemia is part of the risk stratification. So a blood count is important. Assessment of kidney and liver function is important, obviously, because you're going to be delivering cytotoxic chemotherapy to most of these patients. And as the erythrocyte sedimentation rate is one of the factors that is a part of the prognostic index. We also do screening for hepatitis and HIV. Hepatitis can reactivate in the context of chemotherapy, and HIV, as I mentioned, can certainly be a mitigating risk here. Additional pretreatment examinations that are really suggested but not required is echocardiography. In the younger patients, usually they're not going to have some cardiomyopathy that precludes anthracycline. So it's something that we assess, but it's not a requirement, and I certainly do not think that you need to delay therapy or waiting for a 20 or 30-year-old to get an echocardiogram. The same goes for pulmonary function tests. The one thing, though, is patients that are smokers really need to be advised to quit smoking, and I would recommend in that kind of a context to have a proper pulmonary function testing done just to assess the diffusion capacity. Most of the treatments that I'll talk about, like ABVD-based strategies, don't really cause infertility, but generally it's recommended if you're selecting more intensive regimens of therapy like BACOP or escalated BACOP or Stanford 5 regimens or similar things, because there is some risk of infertility associated with those latter regimens. There should be some reproductive counseling, and obviously in women of potential for pregnancy, please make sure that you counsel them regarding contraception and during the course of therapy. Now, the risk stratification, so this is really, obviously the histology matters. Much of the risk stratification I'm talking about is classical Hodgkin's lymphoma. And then in terms of selection of therapy, what really matters are all the other 4 factors that are listed here. And what I'm talking about is really what is the stage, or is it limited stage? And I'm talking limited stage being stage 1 or 2 disease versus advanced stage disease, which is referred to as stage 3 or 4. Involvement of the bone marrow is part of stage 4 disease. I'll talk about poor prognostic features, but that also factors. Presence of constitutional symptoms, or what I referred to earlier as B-type symptoms, that makes it an adverse feature of the disease, and in that context, that makes a difference in terms of selection of therapy. And then also bulky disease also matters in terms of selection of therapy and also consolidation with radiation. So how do we kind of subclassify? Really, for patients with early disease, let me just clarify. for most people as a whole in first-line treatment, we subcategorize them in 3 groups based on what I just described as prognostic groups. Those are patients that are early disease or early stage with favorable prognostic features. There are people that have early stage, again, stage 1 or 2 is what I'm referring to as early stage, but have poor prognostic features. And then there's the category of patients that have advanced disease. Now, let me be specific what I'm talking about in terms of the risk stratification. Again, this is a slide that I borrowed from the European Society of Medical Oncology, and actually purposefully I used their recommendations, even though in the United States we use the National Comprehensive Cancer or the NCCN guidelines. This is a little bit more friendly in terms of taking into account that not everywhere in the world is PET-CT readily available, and this, by the same token, access to some of the resources that one would consider are a little bit more easier to have access to in the United States. The European recommendations tend to take into account kind of perhaps some limitation in resources in terms of stage and prognostic assessment. So I think I find it very useful for our audience and discussion today, since we're talking about an international audience here, and I just actually don't know what's available in which country, really. Now, what is referred to as limited stage or early stage is typically stage 1 or 2. This is based on the Ann Arbor staging. Typically, these tend to be people that have disease above the diaphragm, and they have no other risk factors. Patients that have intermediate stage are referred to, or the other category, by the way, aside from intermediate stage, is referred to as early stage with risk factors. And these tend to, again, be still stage 1 or 2, but they have specific risk factors. And what I'm talking about in the risk factors are at the bottom there: large mediastinal mass, age above 50, elevated SED rate, and more than 4 areas of nodal involvement. This is in the EORTC criteria. You can see similar things on the German Hodgkin study group. The NCCN guidelines has also its own, which is the American version, have its own set of risk factors, but really whatever group you look at, they have similar overlapping risk factors across all of them. Typically mediastinal masses or large mediastinal disease, or what we refer to as bulky disease, is considered adverse risk factor. Elevated SED rate is considered a risk factor. The threshold differs, whether it's 30 or 50, depending on the presence or absence of B-type symptoms, but still an elevated SED rate is a risk factor. And certainly higher areas of nodal involvement reflects a higher burden of disease, and that is separate from the staging, is an added risk factor. What is referred to generally as advanced stages is really people that have stage 3 or 4 disease, irrelevant of their constitutional or B-type symptoms, or really adverse risk factors that I've enumerated at the bottom. These are really, really critical nowadays in terms of guiding the course of therapy. And I just, this is a general slide on treatment approach for early stage disease. We generally do combined modality therapy, which is typically chemotherapy plus involved radiation in most cases. For advanced stage disease, generally the radiation is less often used, and a longer course of chemotherapy is really what is adopted. In the countries where PET-CT is available, or PET imaging is available, this is becoming more and more important in terms of both selection of therapy in the beginning, in terms of adjusting the course and escalating or de-escalating the intensity of therapy during the course of therapy, and certainly in response assessment and prognostic assessment. Much of this is based on the data that I've enumerated here. In other words, we know that patients that have a positive PET, no matter what their CT scan looks like, in other words, they may still have residual masses at the end of the PET-CT, at the end of their therapy. but if they have a positive PET, they have a significantly higher rate of recurrence. By the same token, patients that have a negative PET, even though they may have still measurable CT lesions, these are patients that actually do remarkably well and typically have a much better outcome. And it really reflects the utility of PET in assessing occult disease in someone that may really have radiographically apparent masses. This is classically the case in patients with nodular sclerosing subtype of classical Hodgkin's lymphoma. Again, as the pathology implies, there's a fair amount of sclerosis. And as you can imagine, once the patient is treated in that context, you may have eliminated the malignant clone, but the sclerotic process may remain for actually a long time, and in fact, for even sometimes years. So on a CT, you're going to pick up a mass that is still remaining, and you don't, without a biopsy, you won't know what's there, but certainly the PET can guide in that context and be able to say that there's really no active disease that you can detect. And as I said, a negative PET in that context has significant, a patient with a negative PET in that context has a great prognosis. There's also a fair amount of data regarding use of PET after the second cycle of therapy to be able to escalate and de-escalate the course of therapy, and I'll come back to that. Now, going through some of the data a little bit quickly. I'm sorry, I think I'm just taking too long to do the basics here, but for patients that have early stage, this is one terminology. It's the same terminology is used. It's called limited stage. These patients that have no adverse features. Typically, these patients used to be treated with radiation. There was a randomized trial showing actually that if you do radiation versus chemotherapy, generally the patients with chemotherapy did better. This data is now about 20 years old, but you can see on the left-hand side on the top panel, the overall survival in this particular study was in favor of ABVD versus radiation therapy. And of note, the two groups here where they got either ABVD alone for 4 to 6 cycles versus getting 2 cycles of ABVD plus radiotherapy. And you can see in that, at least in this group of patients, the chemotherapy arm was doing better. If you look at the subgroups, and here I'm talking about the middle group of highlighted there with favorable risk profile. Actually, patients that have favorable risk, if you look at across the outcomes, the overall survival, progression-free survival, event-free survival, it was identical to do ABVD to, it was identical between ABVD versus radiation plus ABVD. So what does this mean? Really that if you wanted to use chemotherapy alone, you can in these patients. And in that context, based on this data, you can do 4 to 6 cycles of chemotherapy alone. If you wanted to do radiation in a patient, you can certainly do that as well. The outcomes are equivalent for early stage. And in that context, you can get away with 2 courses of ABVD plus radiotherapy. One wonders then, why is it that that the patients did poorly in the radiation therapy arm in this slide? This is really primarily when you see the unfavorable risk profile, which were also included in this study. And I can tell you that the doses of radiation on this study were much higher. So really, what came about is that much of the inferior outcome associated with the radiotherapy arm was because of the toxicity of the radiotherapy. So then the next issue that comes up is, can we reduce the dose of radiation in these patients? And can we also reduce the dose of chemotherapy? Do we have to treat everybody with 2 to 4 cycles, or 2 is enough? So there was a very large study. I'm sorry for a very busy slide. I'm actually very famous for making sure that my slides are all very, very busy. But this is a 4-arm study. The design of the study is on the right-hand side. And what you can see is really we're comparing either 4 courses of ABD followed by 30 gray versus 4 courses of ABVD followed by 20 gray. So we were measuring the effect of radiation, or the same design, but in the context of doing only 2 courses of ABVD. So those are the 4 arms. And on the left-hand side here are the patient characteristics. There's really nothing that stands out. And I can tell you really ultimately, as you can see from the curves here, there's absolutely no difference between the 4 arms. So really this led to a standard that for a patient that has early stage, no adverse features, you can get away with 2 courses of ABVD followed by 20 grays of involved field radiation. And that is in fact the standard. And I've put in the table here, and the slides will be available for you guys. You can see in detail here on the right-hand side, the overall survival data and the progression-free survival data. No matter what group you looked at and no matter how we compared them, they were identical across the board. So at least in the patients with early stage disease with no adverse features, the less is better. So 2 courses of chemotherapy plus involved field radiation. And this is again, the ESMO recommendations. If you're doing a PET-based approach, we follow the algorithm on the right-hand side. But if you're just doing, based on the data I just mentioned to you guys, 2 cycles of ABVD with 20 grays of involved field radiation is adequate to cure these patients. If you're doing a PET-adapted approach, again, it's a similar strategy. You do 2 cycles of ABVD, you can do a PET scan. And then on the right-hand side, if they're PET negative, you can opt to do another cycle of ABVD, although you don't need to, and then you need to consider doing 20 grays of involved field radiation. For the patients that have PET positivity after 2 cycles of ABVD, this is a different category of patients, and you do need to escalate the therapy in that context. And at least one strategy would be to escalate with 2 cycles of escalated BACOP and then deliver a higher dose of radiation. And so that's the column there. Just for the sake of not confusing everybody with so much of an alphabet soup, I just didn't want to present the data on the dose escalation, but I wanted to emphasize it in this diagram that for patients that have a PET positive disease, you need to escalate the course of therapy and potentially use something like escalated BACOP and radiotherapy in that context. Now, what do we do for patients that have that do have adverse features? In this kind of a situation, we do certainly recommend more use of radiation in that context. This is, again, a similar 4-arm study. On the left-hand side, there is a blue box here that is highlighting the 4 arms. So this was comparing ABVD versus BACOP. Everybody got 4 cycles of chemotherapy. And then the question was really whether it should be combined with 30 gray of radiation or 20 gray of radiation. And I will summarize it to say really that, first of all, in subsequent studies, we know that essentially ABVD and BACOP are equivalent. And I'll just take this moment to also say that across the board, if you're looking at MOP, COP, ABVD, standard 5, and standard BACOP, they all lead to similar outcomes when you look at various studies. So the chemotherapy regimens are essentially equivalent. Then the question really becomes, for patients with early stage disease with adverse features, should you be doing a higher dose of radiation? And in fact, the answer there is yes. If you're using ABVD, in combination with ABVD, you do need to deliver a higher dose of radiation. So for the patients that receive ABVD, they need to get 30 gray, because you can see that in that category of the patients, their progression-free survival is poorer if they got 20 gray. If they got 30 gray, they were the same. Now, on the other hand, if you're giving BACOP, it didn't matter whether you gave 20 or 30, you can get away with 20. So most of us really end up using ABVD, and in that context, then you need to make sure that you are delivering 30 gray. And again, this is in the subcategory of people that are early stage or limited stage with adverse features. There's a question, should we be intensifying treatment in patients that have adverse features? At least in early stage disease, this is studied multiple times. This is one of many studies. They looked at ABVD versus escalated BACOP. So this is a more intense regimen of chemotherapy in these patients. I can tell you really that ultimately the questions remain unanswered. Why? Because most studies lead to the same outcome, which is that their overall survival is about the same in this category of patients, no matter what regimen of chemotherapy we use. And so it's hotly debated as to which regimen and for how long to do it and how much radiation to give. Largely, the patients that relapse are salvaged and cured with transplant. So that's very hard to prove that, at least in this context, we're going to be able to get a survival benefit, an overall survival benefit by changing the initial induction treatment. Just a very practical point regarding what the dosing is for the ABVD regimen versus something like BACOP. But I also wanted to take this point to just mention to everybody that really part of the reason that ABVD has really taken over as the backbone for most study is that again, as I said, in comparison to things like MOP and BACOP and Stanford 5, they're really essentially considered overall equivalent, except that with ABVD, really you don't need growth factor support. Most patients don't end up having neutropenic sepsis complications. There is very low gonadotoxicity and really no infertility in long-term studies for patients that are treated with ABVD. And there is certainly a lower secondary malignancy risk, mainly really with MDS and AML, which really we do see across the board with other regimens that have alkylators and so on, that including BACOP, escalated BACOP, MOP, and Stanford 5. And that these are primarily the reason that ABVD has become the favored standard is primarily because of these factors. You could certainly, there's institutional bias and favor toward whatever regimen that people are comfortable with. But if you're asking why most of us and most studies end up using ABVD, it's really just because of the better tolerability and toxicity profile in the long term. So for the patients that have intermediate stage Hodgkin's lymphoma, this is a summation slide, so to say, in the sense that you can do 4 cycles of ABVD plus 30 gray of radiation. You can do 2 cycles of ABVD in combination with escalated BACOP and then deliver radiation. If you're using a PET-based strategy, you can certainly de-escalate your therapy in the sense that you don't have to go through escalated BACOP regimens for the patients that are PET negative. So that's on the far right-hand side. You can see the patients that have that receive 2 cycles of ABVD have a PET CT. If the PET is negative, you can get away with 2 additional cycles of ABVD and the 30 gray of radiation, and achieve a high cure rate in that context. For the patients that have PET positive disease, 2 cycles of escalated BACOP is really what is recommended, followed by 30 gray of radiation. What about advanced stage disease? For advanced stage disease, really what the study is, the chemotherapy strategy is this 3-arm study of COP ABVD versus BACOP versus escalated BACOP. And for the sake of time, I would just tell you that really it is much in favor of escalated BACOP. You can see here in the patients that have poor risk group, really the progression-free survival, the overall survival is all in favor of increased dose BACOP, or what we call escalated BACOP. This is, again, something that is used very commonly in Europe and the Middle East. In the United States, it's become less popular because of its long-term association with myelodysplastic syndrome and AML. It's about a 3 or 4% risk on the randomized study. In the United States, CD30 antibody drug conjugate is available, which is brentuximab vedotin. And so there's a randomized study of ABVD versus AVD with brentuximab. Specifically, the bleomycin was eliminated and brentuximab was replaced, really because if you do ABVD plus brentuximab, it's too toxic. So the bleomycin was eliminated. And you can see on the right-hand side, the survival curves there. When you compare ABVD versus what we're referring to as AAVD, which is the brentuximab containing arm, there is a favor toward the brentuximab containing regimen for patients with advanced disease. There's an improvement in progression-free survival. So this study didn't really demonstrate an overall survival benefit. So it hasn't fully been adopted by all institutions, but there's certainly a room to consider this for patients with advanced stage Hodgkin's. This regimen, let me just highlight that this regimen, the brentuximab containing regimen, is certainly much more toxic in terms of neurotoxicity. You can see as much as 5 to 7% of patients have either sensory neuropathy or generalized peripheral neuropathy of grade 3 or more, and that is a pretty substantial morbidity associated with this regimen, and that's kind of what gives us a lot of pause when we're considering this particular regimen. It's also more myelosuppressive for patients. Finally, the final part of the frontline therapy is really, can you use PET to be able to de-escalate therapy? And yes, the answer to this is yes. I'm just going to, for the sake of time, jump into the data set here. This was a study where patients that were given ABVD regimen of chemotherapy, and after 2 cycles of therapy, they had a PET-CT done. After that, if they had a negative PET-CT, in other words, they were in a metabolic response, the bleomycin was eliminated and they just continued with AVD. And what you can see on the top curves there is that patients actually had equivalent outcomes. So this is now the standard, at least in the United States, that for patients that you're giving ABVD chemotherapy, you can do a PET-CT after the 2nd cycle of chemo if the patient is in a metabolic response, in a complete metabolic response, then you can eliminate the bleomycin from the regimen. I would just caution that you cannot do this. You cannot eliminate the bleomycin altogether. There is a separate large study from the Vancouver group, far ahead of in terms of time. It's almost now 2 decades old, that you need a 4-drug combination. So if you're doing ABVD, you need to have, the patient needs to get exposed to bleomycin at least for 2 cycles. And based on this RATHL data, that means after 2 cycles, it's sufficient. So you can discontinue it. In the same study, patients that had a PET positive response, that had a positive PET, in other words, they still had residual disease after the 2nd cycle of chemotherapy, were escalated to either receive BACOP 14 or escalated BACOP. BACOP 14 is basically BACOP delivered every 14 days instead of the standard 21 days. This is a sort of an escalation strategy. And you can see the overall survival is equivalent in that context, but this did not meet its statistical endpoint. So this is open to discussion. I think in the United States, because escalated BACOP is not used and BACOP-based strategies are not used that often, it hasn't gained traction. But in the recommendations from the European societies, you can also see here in the middle column here that if their patients have a positive PET, they do in fact escalate with, they increase the dose of the therapy with escalated BACOP. So this is a summation really for frontline treatment of advanced Hodgkin's. And for the sake of time, I'm going to just actually move on so that I can talk a little bit about recurrent disease as well. In terms of recurrence, it doesn't tend to be a big problem, especially for early stage disease. This estimation, I think, of about 10 to 20% in early stage relapsing is actually, I think, an overestimate on this study. Really, most of the time, it's probably somewhere with the modern therapy, somewhere around a max of 5 to 7%. For patients that have advanced stage disease, it can be as high as 40%. And the time to recurrence matters. It has a very significant prognostic impact. This is a large cohort of patients that actually relapsed within 1 year of their induction therapy had a very poor survival. And you can imagine that's really reflecting, at least in this patient population, in this study, a very chemo-refractory cohort probably, versus those patients that have a late relapse tend to be still chemosensitive and may benefit from subsequent chemo-based approaches and consequently have better survivals. This study is was published in 2002. So nowadays, because of available alternatives for patients that have early relapses, the survival is certainly undoubtedly much higher, but it's worth recognizing the importance of chemosensitivity. Are there prognostic risks for patients at relapse? Yes, it's largely relating to the time of recurrence as well as disease-related factors like extranodal involvement, anemia, and presence of B-type symptoms. In regards to obviously patients that have higher risk features at the time of relapse do poorly. So that's the data here kind of letting you know that patients that have anemia, early relapses, or high burden of disease, which are the patients that have score of 3 on this study, actually had poorer outcomes in the long term. For classical Hodgkin's lymphoma, we do occasionally see late relapses. Actually, let me just very late relapses. So I have a number of patients that relapse, 5, 10, sometimes even 20 years after the initial diagnosis. It's hard to know if this is the same clone as what they had before. There are some studies that suggest that you can treat these patients like a new clone and just give them something like Baycott for 4 cycles. Most of the time, however, what we end up having a limitation on is the patients may have received anthracyclines in the first course of therapy and they're reaching their lifetime maximum of anthracycline-based strategies. And so quite often we end up doing a salvage strategy and transplant. I would be actually curious what you guys and Dr. Shadman, who is at a large transplant center, does for these patients that have very late relapses and have had prior anthracyclines. It's worth a discussion. And of course, it goes without saying that the patients that have primary refractory Hodgkin's do very, very poorly. Their survival, irrelevant of therapy, is really poor even in the modern era. So there's really need for improvement for those patients that have a primary refractory disease. There's a question always that, can you use radiation as a salvage strategy? And the answer to that is yes. I put up 2 of probably over 16 different studies going after this question. And I can just tell you that really across the board, as I've highlighted there, for the patients that have stage 1 disease at the time of relapse and no high-risk features, you can actually cure these patients and give them a reasonable chance at a durable remission and overall survival with radiotherapy. For patients that have more advanced disease, and certainly those that have a more widespread disease, it's either impractical to deliver radiotherapy as a salvage strategy, or generally their outcomes are not going to be that great. Now, for the patients that can tolerate in the relapse setting, our standard is to offer an autologous stem cell transplant. This is the original data set that was published in 2005 of using 2 cycles of chemotherapy, and those patients that have chemosensitive disease as assessed by radiographic response went on to receive an autologous stem cell transplant. And as you can see, those patients that received an autologous stem cell transplant had better failure from treatment, 49% versus 32%, and that is statistically significant. There are a number of regimens that you can use to get the patient or to test out if the patient is sensitive to chemotherapy. I've highlighted them here, and across the board, with the exception of the GDP regimen that is in the middle here, most of the other regimens tend to have really high overall response rates. So Dexabeam, Minibeam, ICE, IGEV, MIND, they're all really above 70–80% response rates. And so you can test out if the disease is sensitive to the chemotherapy and move the patient to transplant. Sensitivity to the salvage chemotherapy matters a lot. Here on the, you can see the patients that have chemo resistance to the salvage regimen really have very poor outcomes with transplant and really will not benefit from transplant, although patients that have only a partial remission there have a poorer outcome than those patients that have exquisitely chemosensitive disease where they indeed achieve a complete response with the salvage regimen. One thing I would like to highlight, though, is that a lot of these studies are actually done at the time where we used to use CT scans for assessment of response. Nowadays we use PET-CT. So you could say back then somebody may have been labeled as a partial response because they had a residual measurable lesion on CT. If you had the ability to do a PET back then, this might have actually been a complete metabolic response, in which case it would have been probably a patient that is clearly has chemosensitive disease and would benefit from transplant. So there is some value, number one, to doing the PET, but also there's some caution in terms of interpreting these particular set of studies that are done prior to the PET era, because again, especially in classical Hodgkin's lymphoma, you can have residual masses that are metabolically negative, and indeed the patient is in a complete remission. This highlights the question of stem cell transplant for refractory Hodgkin's lymphoma. A lot of groups have used to advocate for it very heavily, including the Vancouver group and the Princess Margaret group in England, because of the data that they have that I've presented here. But again, the problem is the assessment of response. And so if really we had nothing else in the modern era, it would be worthwhile repeating such a study or such an assessment for refractory Hodgkin's lymphoma, taking into account PET as a response assessment criteria. Now, is there a role for tandem transplant? This is the joke of oncology. If something is good, maybe more is better. There is some suggestion that the patients, and you can see here on the blue line, these are patients that received a tandem transplant. And this, because of the flattening of that curve, there's some suggestion that somewhere around 40 to 50% of patients can actually have durable remissions if they're offered a tandem transplant in the high-risk group. And so there may be some role for a consideration for tandem transplant. Finally, in the relapsed refractory setting is the question of the PD-1 blockade. I already mentioned this as a part of the biology of the disease. And you can here, I can highlight for you one of two studies here. This is the original pembrolizumab study, 210 patients. Either they progressed after transplant, or they couldn't get to transplant because they had chemorefractory disease, or they had a transplant, and even after transplant, there was failure of the transplant strategy. And across all categories, you can see responses. The overall response rate is around 72%. Complete responses are around 28%, and partial responses around 45%. But what is more impressive is a lot of these patients have at least reasonably durable remissions, even despite partial responses and stability of disease. So there's a significant clinical benefit that is achieved from the PD-1 blockade. And as I mentioned, the median progression-free survival at the bottom there is really not reached across for patients that, for example, achieve a complete response. They have pretty durable remissions. In the United States, the other PD-1 blockade that has been heavily studied is nivolumab. So I'm just purposely being balanced to present both of them. But one thing I wanted to highlight is that we are now trying to combine nivolumab with, or PD-1 blockade with brentuximab, which is the CD30 antibody drug conjugate. You can see on the left-hand side, across the board, a lot of the patients, these are all group of patients that have relapsed refractory disease, including have had chemotherapy and stem cell transplant. They did not have prior brentuximab, but you can see across the board, a lot of them are in fact responding and achieving deep remissions with CRs and PRs in this context. I'm going to stop there. I think my slide said actually somehow, but I'm going to stop there and answer any questions.
I don't know if Dr. Voisey is on for moderating the questions.
I can go into the chat box here and see the questions. I don't know if Dr. Voisey.
Yeah, I don't see a question in the chat box.
Oh.
But while we're waiting for Dr. Voisey, maybe there's some technical difficulties. Oh, there's a long question.
I see the long question here.
Yeah, let's start with the smaller. So if Dr. Voisey, I think he may be having some technical difficulties. So the question is from Dr. Mir Hosseini. Thanking you for your talk. And in which patients at first relapse you do not recommend stem cell transplant? Let's start with that while I read the next question.
You know, really, if the patients are, so in all of the patients, we try to deliver curative therapy. That's the initial goal. And really, the best data for that comes from a stem cell transplant. So unless the patient really has either comorbidities, cardiac issues, or some other condition that precludes them from going to transplant, still our goal, even in a patient that has primary refractory disease, is to get them to transplant. So in that context, we would give them a salvage regimen. Obviously, we know that as I showed, you know, patients that have very quick relapses within 3 months of the initial induction, or primary refractory where they are progressing even during the course of the ABVD or whatever, those patients may not do well and they may not be able to make it to transplant, but at least we give it a shot to get them to transplant, to at least see if the disease is sensitive to a different regimen of chemotherapy, knowing that it may not be the case, but we would try. So there's no, so the direct answer to your question is really for everybody that is potentially eligible to go through transplant, I would offer a transplant. Then we test it out, as I already mentioned. Can they tolerate the chemotherapy? And also, is the disease sensitive to chemotherapy? That is assessed by salvage chemotherapy. Nowadays, though, in contrast to 15 years ago when I started in the field, we used to go from one regimen of chemotherapy to another until we got some response and then take them to transplant. Nowadays, really beyond 2 regimens of salvage, we don't necessarily say you need to do more chemotherapy. We would, especially in the context of the checkpoint inhibitors, the PD-1 blockade, and all the other options that we have available, typically we would move the patient to that sort of an immunotherapy strategy. That's a major issue, though, because those strategies are not considered curative. And so we are basically eliminating, or the patient would not be eligible for a potential curative strategy in that context.
Thank you. So again, I don't know if Dr. Voisey is back, but I'll continue. And please let me know, Dr. Voisey, if you're back on. So and that long question is actually a combination of a number of smaller questions. So I think to combine the first 2, do you, in order to use brentuximab vedotin, do you need to confirm CD30 expression, or by definition classical Hodgkin does express it and you just give it? And then maybe the second part, in CD20 positive Hodgkins, would you add rituximab?
Yeah, so again, for most patients with classical Hodgkins, that's part of the assessment of the Hodgkins on histopathology, and so we don't necessarily confirm or reconfirm that CD30 expression is there. we assume that's there. This is kind of the biology of the disease. For the patients that have CD20 expression, I don't know if I necessarily, well, actually, I have to admit, first of all, we don't routinely check for CD20 expression on all patients with when the diagnosis is Hodgkin's. And I don't routinely, even if it's expressed, don't routinely add an anti-CD20 monoclonal antibody to something like ABVD. I'd be curious what Dr. Shadman and some of the others do, but I don't routinely add that to the regimen. Not because of the toxicity issue, it's just really what drives it is really what drives our treatment decisions and selection of therapy is really what I alluded to in this talk in terms of the prognostic factors. And so I don't necessarily add anti-CD20 in that context.
Yeah, no, I agree completely. Okay, moving on to the next question. So that's actually a kind of a common good question. So let's say somebody's after 2 cycles, there's a Deauville 4 or 5 PET, and you don't escalate to BA cup, which, as you said, we don't do it in the US either. I see Dr. Weiss is back too, but basically, what would you do in that situation if you need to escalate and you don't want to use BA cup? What would be your approach? And maybe after this, I'll let Dr. Weiss continue.
Yeah, so that kind of a patient would worry me a lot. So in that context, it really depends on where and how much of the disease. So if the patient has one node or something like that, where or a localized area that is the only site of active disease. One thing I would certainly do in these kinds of cases is really I reattempt a biopsy, because occasionally patients have composite lymphomas. Occasionally they have something called gray zone, which looked like Hodgkin's, but it may be a Hodgkin's plus something, not just a composite, but really a features between DLBCL and Hodgkin's. So in other words, I would have a high index to rebiopsy and make sure I'm treating the right thing. And then if it's just localized, one could certainly continue with ABVD plus delivering local radiotherapy to that site. If it's much more widespread, then for that particular category of patients, I would worry that they really have primary refractory and move them to a salvage regimen of chemotherapy and potentially consider a transplant or an immunotherapy-based approach.
Yeah, no, I think what you mentioned is very important. I mean, there's Deauville 4 and there's Deauville 4. Sometimes, there's a Deauville 4 with a very good partial response, and in those cases, we would usually continue with ABVD and complete the full course. If there's a Deauville 5 and that's clearly progression, then that's a different story. You biopsy, and sometimes in these patients, and I think there's some data from Italy too, that you just move to platinum-based salvage and even auto. If you know that somebody's primary refractory to ABVD, there's no need to waste the time of patient. And so, yeah, I think Dr. Weisey, I saw him back, so I will let him continue the moderation. Thank you.
Yep, I'm here. Here is a question. Question is written here. I have a young patient that is case of classic Hodgkin lymphoma, advanced and he has TB, tuberculosis. What's your drug interaction, berentuximab? Have you?
It's an interesting question that you mentioned, actually. Thanks for bringing it up, actually. I very interestingly, over the past, so when I was a resident, I should say, we used to screen everybody as part of the initial testing that we used to do. We used to check HIV and hepatitis and TB. Then it fell out of favor largely in the United States. And interestingly, in the past 3 or 4 years, I've had patients that have had one of whom had a widely positive PET CT throughout the bones. I thought he had widespread relapse, and he was biopsied, and it was actually miliary TB. So we have now started actually screening everybody for tuberculosis, because it can certainly reactivate during the course of chemotherapy. So that's, and thanks for bringing this up. And I think this is something, especially in areas of the world where TB is endemic, or even in patients in the United States, patients that have risk factors for TB really should be screened in the beginning. In regards to the drug interaction issue between rifampin and Etcetris, I actually have to admit, I generally, let me just see, the question is, would you recommend treatment regarding major drug interaction between rifampin and Etcetris? I generally, in this young patient that is going to go through, potentially you're recommending some sort of a salvage to get them to transplant, I assume, because it's a young patient. In that context, then I decide really how quickly do I need to treat the Hodgkin's. Hodgkin's, some patients really have very explosive, rapidly evolving disease, in which case they cannot wait. And in that context, you need to start the chemotherapy and also treat the TB concomitantly. For some patients, they have a little bit of a more indolent course, in which case you can actually deliver therapy for the TB for a few months before treating. So then you have to decide, my point is, how quickly to treat the underlying disease. And then ultimately, as a salvage strategy, I don't generally use brentuximab-based strategies. Generally, we at our institution, for young patients with Hodgkin's, they usually get IGEV or a platinum-based strategy, which is a much more intensive strategy. We have been somewhat underwhelmed by the overall response rate for brentuximab in the salvage setting. And there's also an element that we always want to test out and make sure that the patient can tolerate aggressive chemotherapy. So based on those parameters, generally we don't end up using brentuximab in the salvage setting. So this drug interaction issue is not something that I have to admit I have come into. Now, if you're planning on using Etcetris, I actually don't know, honestly, how to guide you on this. Yeah. I don't know if Dr. Shadman, he sees a lot of transplant patients, maybe he has better guidance than I do.
No, I mean, I don't have much to add. I mean, I think there are just many salvage options that do not include brentuximab. And none of these salvage regimens have been shown to be superior, right? I mean, we use very commonly ICE. We use these days, sometimes we replace our phosphonamide with bendamustine, and we use what we call TEX, or bendamustine etoposide, and carbo. You saw the recent data with Pembro and GVD, although in the setting of TB, but yeah, I mean, ICE and even gemcitabine-based salvages are as good as any other salvage. So I don't think we have to necessarily use brentuximab. If they have received the line and they still need a second salvage, that's a different story. But as you said, in Hodgkin, you usually have the luxury of waiting a little bit and treating the infection, and maybe your drug interactions are less relevant. But yeah.
Yeah, I think that's actually a big deal also, because again, if you're talking about a young patient, you're ultimately trying to get them to transplant. So the TB has to be under control. So you have to kind of judge and see how quickly you have to jump on the anti-neoplastic therapy for that patient.
We have some questions here. One question is, when do transplantation? If partial response is enough, or you give the patient another salvage and to achieve complete response, and then proceed to autologous. We check CT scan or PET scan to recognize the confirmation. Is a question about when we do transplant, autologous transplant.
That's a good question. So there's a couple of things. One is, as Dr. Shadman actually just eloquently said, there is a PR and there's other PR. So there, it all depends on what we are referring to as a PR. Sometimes patients have, again, 1 or 2 small lymph nodes that are just barely above the mediastinal background or above the liver background, in which case then they're, by criteria, they're labeled as Duval 4, and the bulk of that residual disease is minimal, in which case then we would say, okay, that patient probably should proceed with transplant. But if the patient has really widespread disease that is metabolically active, that is labeled as a PR even, that would worry me about moving to transplant. And in that context, if somebody has clearly a progression, has improvement of the disease burden toward response, then we would do maybe another 1 or 2 courses of salvage, and then of the same salvage or even something else. But if there is clearly evidence of response, this is where really it's not just simply checking boxes. You have to look very meticulously as what was the burden of disease before, where was it, how much of a response are we actually calling a PR, and what's the quality of the PR. Contrary to this, or in contrast to this, if somebody has a PR and has very large masses, generally that's kind of declaring itself that it's not sensitive. I can also tell you that universally, at least at my institution, our criteria for response is a PET response. So we don't use CTs alone for assessment of this, because notoriously for Hodgkin specifically, again, as I've already emphasized, people can have masses that are radiographically apparent that are metabolically inactive, and they should not be deprived of transplant if they have had a metabolic response.
Thank you. About nodular lymphocyte predominant Hodgkin lymphoma, what's the best treatment for this type, non-classic Hodgkin?
Yeah, so I purposely stopped before rambling on for too long because I was taking too much time talking about this, but I had a few slides on this. I would just sum it up to say, typically we treat that entity like an indolent non-Hodgkin's lymphoma. So nodular lymphocyte predominant Hodgkin's is generally CD20 positive. So most of the time in that category of patients, we actually do frontline anti-CD20 monoclonal antibody, quite often as a single agent. If the response is inadequate or the patient has persistent symptoms, we quite often add chemotherapy like bendamustine to the regimen. So similar to what we would do perhaps, with a patient with follicular. I must say, though, that if you look at a lot of the German Hodgkin study group, across the board, a lot of they included nodular lymphocyte predominant Hodgkin's in their studies. So there is clearly both efficacy and safety data with ABD combination, because that's what or BACOP even, because that's what the studies were. So point being that there is no universal standard, I would say, and I think we treated more like an indolent non-Hodgkin's lymphoma in terms of a treatment strategy, but there's room for advanced chemotherapy or more toxic chemotherapy as well. One thing I would highlight, though, that I actually saw a manuscript relatively recent, and I think we are going to be subdividing nodular lymphocyte predominant Hodgkin's into, there is a more aggressive variant of it with extranodal involvement and aggressive clinical behavior. And so there is a subcategory of nodular lymphocyte predominant Hodgkin's that should really receive more intensive chemotherapy. It's hard to identify it now, but clearly in retrospective studies, it's showing that, that there is a subcategory that clinically has a different behavior.
Thank you. Another question is about when we treat the patient after with ABVD, and after 2 cycles, we do PET CT, and in PET CT shows dual 4 or 5. If we can't use vehicle, what do you your recommendation about continuing the treatment? If you do you recommend to do biopsy or continue the ABV or other treatment strategy do you recommend?
I see. So this is really so I'm just clarifying. So this is during the induction is when they did the scan, and after 2 cycles of ABVD, that's when they saw the Duval 405. That's what you're saying. I think they're talking about during induction. So this is kind of what I was mentioning earlier in that context. It just depends on what it is that we're calling Duval 405 and how much of it is there. So again, if it's just one particular lymph node or a lymph node group that is super hot on PET CT, number one, I would biopsy it to make sure that it is truly Hodgkin's, because there are people that can have composite lymphomas, or in other words, they can have diffuse large B cell at the same time, or some other malignancy for that matter. So I would have an index of suspicion to make sure that I'm treating the right thing. And if that's the case, and if I prove that it's still Hodgkin's, then in that kind of a situation, you can consider, if it's again a small group of nodes, you can consider continuing ABVD and then irradiate that lesion. But it would worry me that a biopsy-proven recurrent Hodgkin's not responsive to ABVD, that's going to be enough to kind of irradiate that. So I would have again a very low threshold of switching the therapy in that context to, I guess they don't want to use BACOP, then some other regimen for sure. I don't know if that answered the question. I think it all depends on really, perhaps actually one thing I must say is, we generally have a tendency to just give these scores like Duval 4 or 5, but quite often I actually emphasize to our fellows to actually look at the scan themselves and see what the radiologist is talking about. Again, because it matters how much and where this Duval 4 or 5 is. If the whole disease is just not responding and is still persisting at Duval 5, so multiple lymph node groups are that's a very, very refractory disease, in contrast to just one nodal group having Duval 4 or 5 and everything else is responding exquisitely.
Thank you. Here is we have a question about relapsed refractory Hodgkin lymphoma. The patient received chemo, then immunotherapy, and the patient is in complete response. Do you recommend to proceed him or her to autologous, allogenic, or continue the immunotherapy?
Yeah, so there's that requires some assessment here. So there's a couple of things to take into account. As a whole, there's 2 issues with allogeneic stem cell transplant. One thing is that I just don't know truly if what you get out of an allo transplant, what we are looking for out of a transplant, which is a graft versus lymphoma effect, graft versus Hodgkin lymphoma effect, that may not be all that strong. So we generally, as a category, don't do allogeneic stem cell transplant for most patients with Hodgkin's, just because I don't know how much this benefits them. The other is a practical point to take into account, that the patients that are getting immunotherapy, you're talking about checkpoint inhibitors, you need to have some either alternative strategy for your allo if you're doing it, because these patients are at risk for severe graft versus host disease if they're coming off of checkpoint inhibitors. So you either have to stop the checkpoint inhibitor months in advance to allow it to wear off, and so you don't. And typically at our institution, if we're doing a checkpoint an allo transplant after someone has received a checkpoint inhibitor, we would do a post-transplant Cytoxan-based strategy to mitigate the risk of graft versus host disease. So just, it's a practical thing. If you're proceeding with the transplant after checkpoint inhibitors, you have to anticipate and alter your regimen because the patient has been exposed to checkpoint inhibitors and has a high risk of graft versus host. The other thing is, going back to what do we do for a patient that has received chemotherapy and immunotherapy, there's an interesting concept, and in the sense that Dr. Moskowitz, actually from, I think, Memorial Sloan Kettering, presented some data of patients getting brentuximab plus nivolumab and then going to transplant. And in that context, we are thinking that the addition of the immunotherapy is actually making this disease sensitive to chemotherapy. This requires further evaluation. But if that's what the person who's asking a question is saying, that they added immunotherapy to chemotherapy and the patient is now having a response to chemotherapy and has achieved a remission, then you would say maybe they would indeed be sensitive, the disease would be sensitive enough to benefit from an autologous stem cell transplant. I think most of us, again, would probably offer, just kind of the devil's in the details. Most of us, if really truly patient, let's say, got brentuximab plus some immunotherapy and has achieved a response, then we would say with caution that that's chemosensitive and I would offer an auto transplant. But really the details matter.
Thank you. Is there any concern about,
I think Dr. Shadman had a comment.
No, I haven't. I just I think this is a question that comes up very often, and you responded very nicely for allo. But I think, like, let's say a patient who relapsed patient, they get one line of salvage therapy with chemotherapy, still active disease, and you give them single agent pembro or nivo, and they do achieve a remission. Usually we think of auto transplant for patients who are chemosensitive, but now you have a patient who is in remission from immunotherapy and not chemo. Would you still recommend auto? And we know there's not much data, but I think I thought maybe part of that question is related to, maybe I misunderstood it, but would you offer auto transplant to somebody who's in complete remission with a checkpoint inhibitor and not chemo? And yeah, again, it's kind of a data-free zone, but different practices, I guess.
Yeah, I have to say, again, at least in that, thanks for clarifying it. I think you're right. That's what the questioner may be going after. In that context, I would be very hesitant to say the patient should go for an autologous transplant, because I don't know if the response to the immunotherapy, the checkpoint inhibitor, is going to be a marker for the sensitivity to my conditioning regimen in transplant. Although, again, in this day and age, you could say, well, the disease is now maybe turned sensitive by virtue of the immunotherapy, but we don't know. I would be very cautious. I mean, it's a big bar. I try not to take away the option of transplant, because that's really the curative strategy at this point. So we try in every way, and that's where I would really perseverate almost and obsess over the details here. But in a pure fashion, if somebody has chemorefractory disease and I gave them immunotherapy and that's what they responded to, I would keep them on immunotherapy.
Thank you. Is there any concern about brentuximab usage to affect harvesting before autologous hematopoietic stem cell transplantation? Is there a concern about its usage?
Not specifically with brentuximab. It's an antibody drug conjugate. It should really technically bind and be absorbed by CD30 positive cells. I think there is some of the drug conjugate that is probably not attached to the antibody that is the only way I can explain some of its off-target toxicity, like neurotoxicity and so on. The MMA that is attached is actually pretty toxic chemotherapy on its own. But I'm not sure that it has necessarily significant myelotoxicity, and I have not had any collection issues if I've used brentuximab. Usually it's because they've received a lot of other chemotherapy that they're having issues with collection.
What's your opinion about the haploidentical allogeneic stem cell transplantation relapsed refractory Hodgkin lymphoma?
Yeah, again, I just in general express some caution regarding allogeneic stem cell transplantation for patients with Hodgkin's, both because of, again, there's no clear data that the graft, whether it's coming from a haploidentical donor or any other source for that matter, provides much of a graft versus lymphoma effect. There is some suggestion of that because if you look at long-term survivors after an allotransplant for Hodgkin's, the ones that are long-term survivors tend to be the people that have some degree of chronic graft versus host disease. In other words, they have an active graft, and that's also potentially providing them some degree of disease control. But that's the extent of it. But there's also a practical thing here because you're also putting the patient at risk of all the complications associated with an allogeneic transplant, which is not easy, with including mortality in the first few years associated with that transplant strategy. And then there's also a practical issue that for someone like myself who runs a lot of clinical trials, most of the time, if I give somebody an allo transplant, they really quite often become ineligible for other salvage strategies that can actually provide a much better quality of life and including much more durable disease control. I can tell you at our institution, we were, in regards to the original study of checkpoint inhibitors, my colleague John Timmerman was got on the bandwagon with that a very long time ago. So I have now patients in my practice and in the UCLA group as a whole that are on immunotherapy in excess of 6-7 years and continuing on one form or another of immunotherapy with checkpoint inhibitor and various newer checkpoint inhibitors on various trials with good quality of life. We see them every 3 or 4 weeks for their immunotherapy. The disease is controlled, maybe not in remission, but controlled. So I've avoided the toxicity of an allotransplant. They're living, have not died from an allotransplant. So that was a very long answer to a haplo question. I don't know, and I don't know the value of an allotransplant. The other thing also I must say is, I don't consider myself a transplanter. I do transplants if my patients need it, but really it's not my area. So I do have a very significant reservation across the board using allotransplants for lymphoid malignancies as a whole, just as a bias, I should say.
Opinion of treated patients. Some pediatricians ask about ABVD in induction treatment. How?
I'm sorry, the connection was a little difficult.
Yeah.
I think you're asking about a pediatric patient. Is that
question,
what you said? Yeah.
Question? Yeah.
Yeah. So I don't treat enough pediatric patients to be able to honestly comment. There's a major issue for pediatric patients because they're certainly, especially in adolescence, the bone structures are undergoing development, and so that needs to be factored in. But I honestly don't have enough experience for pediatric patients to be able to comment on an appropriate regimen for pediatrics.
Thank you so much. Thank you for your informative lecture. And if there is any question or comment, we continue, or if there is no comment, any question, we can finish the webinar.
Can I, Dr. Wizy, if I may, just one quick comment. I think I saw a question about the consent. Can you hear me?
Yes.
Yeah.
Yes.
The question about concern for collection was with bendamustine, I thought. I just wanted to maybe ask a question because this is a practical point. So when you collect stem cells for auto, do you usually, in Iran, do you usually collect it off chemotherapy, or do you usually collect off GCSF and plerixafor? I don't know if you can hear me, Dr. Wizy, or one of our colleagues in Iran. The question was about bendamustine and causing issues with the stem cell collection. I was wondering if your usual practice is to go right after chemotherapy with GCSF and collect off the nadir, or do you wait and give growth factor with plerixafor and collect off GCSF? Yeah, sounds like
bendamustine. We use bendamustine. It was a clinical trial that we use bendamustine in conditioning regimen in autologous stem cell transplantation. Really, I don't know the result and don't know that. I know that we use carboplatin in this conditioning, and the result was good. But about bendamustine is a trial that I asked Dr. Musavi or Dr. Rostami to help about this question.
Thank you. Hi, Dr. Musavi.
Hello, I'm Dr. Musavi. I'm glad about your participation and nice presentation, Professor Eradat.
Thank you so much.
Friend. Thank you, my friends, Dr. Shadman, for your nice coordination, and thank you, my colleagues, Dr. Wazi and Dr. Yagmai, for nice moderation and facilitation of this webinar. We have a study with bendamustine in conditioning regimen of Hodgkin's lymphoma. We have no any other information and data about effect of bendamustine. One study from France show no difference between beam regimen in conditioning regimen and bendamustine instead of BCNU or carmustine. I don't have any other data about role of bendamustine in conditioning regimen.
Okay, no, thank you. This is really helpful. So the question is really before transplant, and I think the question from Dr. Peykar was, when you use bendamustine as salvage, are you concerned about the stem cell collection? And I think this is an issue that I wanted to share because we had the same problem. Yes, it's difficult to collect off bendamustine, meaning that when you try to collect off a bendamustine regimen, it's difficult. If it's not combination, the patients usually don't drop their counts, so you don't know when to start the GCSF, and it's very unpredictable to collect stem cells off a bendamustine only regimen. But once we added a topozyte to it, for example, then that problem was resolved. They get a nadir, and then you know when to add GCSF and you collect them. But if you don't collect, that's why I asked the question, if your practice is to wait and go with GCSF and plerixafor, then that wouldn't be a problem. There's no problem with collecting off bendamustine. We have published it that patients who got bendamustine salvage we had a very high, we were very successful, 100% in collecting the stem cell. If we use GCSF and Mosibil, Plerixafor later and not off chemotherapy. I thought that was the question. If it wasn't, sorry, but I think it's a practical point that we had to deal with for a while. So I thought it was important to share. Thank you.
Yeah, it's important. I actually wanted to clarify. I think I heard the question as brentuximab. So the whole CD30 discussion and so on, please just be aware of that. But I share exactly what Dr. Shadman said in regards to it's a very reasonable strategy as you're using it as salvage. But if you don't know how low the counts are, you don't know when to start the GCSF for collection. So it just becomes a logistical and pragmatic issue that you have to address. But you should be able to collect if you take that into account.
Thank you.
I think we're having some connection issues, but.
Thank you, Dr. Eradat, for your nice talk. Did you answer all the questions? Anybody have other questions? Dr. Shadman, can you hear me?
Yes, I can hear you.
Okay. I think Dr. Eradat answered all the questions and we can finish the program.
Thank you very much. It was a great
Thank you very much. Thank you, Dr.
Thank you again. Thanks for having me. I appreciate it. Thanks. Take care.
Thank
Be
you.
well,
Bye.
everybody.
Thank you. Bye.
Bye.
Bye.